Well, first of all, I'd like to, thank you for having me here today. It's my pleasure to speak to you. It's not often that I get to speak to such a large group of Girl Scouts from Troop 101, but happy to have you here today. So, I'd like to also thank my colleagues at University of Pennsylvania, Nora Sandorfi and Chris Dirk, for their expertise and their training when I was a fellow and allowed me to speak with you on some of these issues today. So we're going to talk about Raynaud's. So Raynaud's was first discovered by Maurice Raynaud, who is a French physician in a long line of family who were physicians, in 1862. And he described it as a local asphyxia of the extremities, basically loss of oxygen to the tissues. Anytime you have loss of oxygen, you undergo a certain degree of hypoxia or lack of oxygen to the tissue, and you can have a variable degree of skin changes, including death. So when we talk about some of the fundamentals of Raynaud's, we have to talk about the vascular system, and this is from the NIH. We have, fortunately, a vast network of arteries and collaterals, and when we have the big branches of arteries coming off, they get smaller and smaller, of course, going to the finger, and then they eventually branch off into what's called capillaries. Part of Raynaud's, whether you're talking about Raynaud's with scleroderma or other factors, is a vasoconstriction. And a vasoconstriction, if you compare here, would be a normal pipe with a lot of room for blood to flow versus a pipe that has a lot of, let's say, lime deposit, very narrowed, very stenotic, and very little room for blood to flow. So the amount of warmth, the amount of oxygen your fingers will get is proportional to the size of the pipe that's feeding them. So when you have Raynaud's, the pipe is smaller, resulting in these finger changes in this diagram. If we could dim the lights just a little bit. Great, thank you. So when we talk about the end of arteries, we talk about capillaries. There are two places in the body you can see capillaries, which are the smallest artery that blood can flow through. And that's in the back of the eye, so if you go to the eye doctor, they can certainly take a look. And then also in the nail bed. So if you look at your nail bed with a naked eye, you'll see redness, but what you're really seeing, if you can see it under high degree, is you're seeing capillaries. So in the office, what I do is I use an ophthalmoscope, which is used for the eyes, to look at the fingernails. And right at the base of the fingernail, you can see the skin right here, and up here would be the fingernail. You have a nice array of, looks like straight lines coming in and feeding the tissue. So this would be a relative normal capillary blood flow. And these straight lines, if you could zoom in further, you'd see a loop, and that's where the capillaries end. If you look at a patient with Raynaud's or scleroderma, this one happens to be Raynaud's with scleroderma, you see a definite change when you look at these capillary loops compared to these. These here look very uniform. These here do not. You can see dilation. You can see blood that seems to be leaking out of the capillaries. Oxygen is not getting to these fingers. This is a closer magnification of what you would see. So when you look again at normal here, you can see a nice loop. Comes up, goes down, comes up, goes down. And this is oxygen that's going to be coming out of these loops and delivering to the tissues in a very warm and comfortable finger. This, with scleroderma and Raynaud's, dramatically different. We have at least 4 times fewer capillary loops here to begin with. So now you're talking about tissue in between that's not getting fully oxygenated. And then you have dilation of loops, which is probably a lot of changes in the interior of the vessel and an enlargement of the vessel, but not necessarily improvement or oxygenation. If you were to do other studies, which we don't often do, but for educational purposes, this is what's called an angiogram. An angiogram would be dye that would be injected into the system, and then under a radiographic procedure, you would radiographically evaluate or look at the vessels. So it's probably easier to see the one on the right. They actually are the same photograph, but I think it's easier to see this over here. These are the main blood supplies to your hand. One's called the radial artery, the other one's called the ulnar artery. They make a collateral of vessels that come and are supposed to go all the way to the fingers. You can see the fifth one here, you're getting some blood supply, but then here's the ring finger, here's the middle finger, here's the index finger, and here's the thumb. Very little blood supply going to those fingers. And you can actually see a cutoff right about here. So oxygenation very poor in this patient, Raynaud's confirmed, and a potential for necrosis or skin tissue death. There are two types of Raynaud's, and I think we have probably different patients here in the audience today. The first type is called primary Raynaud's. Primary Raynaud's just means that you have Raynaud's for no reason that we can diagnose. So that means you don't have history for a frostbite, you don't have a history for scleroderma, lupus, or an associated disorder. So it happens, it's what we call idiopathic. There's no specific cause to it. The other one, secondary Raynaud's, is what we generally refer to as an association with systemic sclerosis, or what we often term scleroderma. But secondary Raynaud's can be related to medications, can be related to frostbite as well. So primary Raynaud's usually occurs between the ages of 15 and 30 years of age. It's more common in women. Raynaud's in general is more common in women, both types. And it may occur in multiple family members. Again, this is primary Raynaud's. This is an unknown reason of why these attacks occur. For primary Raynaud's, what we like to define as symmetric episodic attacks with skin color change, and that's usually pallor, so it's white, blanching color of the skin. That's followed by a bluish cyanotic tone, and then often a red rewarming. And of course, primary Raynaud's can be associated with gangrene, but scleroderma and secondary Raynaud's is where we usually see it. Again, it's not usually seen for gangrene in primary, but it can. So secondary Raynaud's, secondary causes to another condition. This is the most common with scleroderma. But I think it's important to note, if you have scleroderma, you have secondary Raynaud's, but you can have secondary Raynaud's to scleroderma and also secondary Raynaud's to another factor. So for instance, if you have scleroderma and you smoke tobacco, perhaps the tobacco is worsening the underlying issue of the scleroderma causing the Raynaud's. So you have to include medications in there. Certain high blood pressure medications called beta blockers, which they use for hypertension. Probably the most common one is metoprolol, can cause vasoconstriction or narrowing of the blood vessels. Certain medications for attention deficit disorder also can cause the same effect. And I actually see patients with primary Raynaud's who are younger and diagnosed with primary Raynaud's who are on attention deficit hyperactivity medications. When they come off, they actually improve or the Raynaud's resolves. So they were inappropriately called primary when it was a secondary medication causing the condition. And then if you're where I'm from, in Michigan, where I grew up, frostbite is a common cause for these conditions. Frostbite not only from significant frostbite of gangrene, but what some people would call frost nip. And that's, you had significant damage from the cold weather to the nervous system areas, maybe not enough to cause gangrene, but enough to make you hyper-responsive. My manual laborers who work with vibratory equipment like drills, jackhammers, they can also cause a similar condition. So this is secondary Raynaud's with systemic sclerosis, scleroderma, and this is what we call sclerodactyly. So sclerodactyly is a tightening of the fingers of the skin, usually from this part of the finger down. With this patient, it's pretty significant, and you have involvement all the way up the palm. You can see that over time, the Raynaud's as well as the scleroderma has led to what we will call atrophy or loss of tissue at the very ends of the fingers, and the fingers are significantly changed. So they don't have that nice tissue padding that a normal finger would have at the very end. Some of the other scleroderma features that those of you who have scleroderma would recognize immediately would be the dilation of blood vessels, which we call telangiectasias. So this combination of tightening of the skin, telangiectasias, loss of tissue at the end, those are typical for scleroderma, and also we have our Raynaud's. This is looking at from the other side. I think you can see the tightening. Normally, if you have a less tense skin, you don't have this shininess of the light coming off of the skin. And actually, if it was a better picture, you would see a loss of pigmentation. Sometimes they call salt and pepper deformity. The pigments are being basically stretched apart, and you're seeing loss of pigment in between. You can kind of see in this picture, though, redness at the very bottom of the fingernail bed. And if you were to look close, like those previous pictures, you would see significant loss of capillaries, and you'd see dilation as well. And just another picture, we see hand contractions. When you have sclerosis from scleroderma, it's often to develop into a somewhat of contracture of the fingers. So these fingers actually will not extend. This is a full extension for these hands. And again, you can see some curling under, which is another sign of these changes, and certainly loss of some oxygenation of the tissue. So let's go back to this. So we talked about a dilation of the blood vessel in the normal extremity, giving you blood circulation to capillary beds at the fingers. We talked about issues such as vasoconstriction, whether it's either primary or secondary, primary with unknown reason, and secondary, we'll say, with scleroderma or other causes, causing vasoconstriction or a narrowing of this pipe, similar to what you would see in plumbing if you had a lime deposit. So if we were to take a biopsy of small arteries or capillaries, in a normal patient, we would see a cross-section. If you were to cut it down the middle, you would see a nice ring, and there's tissue in there, this is muscle, and then there's tissue surrounding it. A few blood cells in the middle, but you can see this nice big area. That's a nice big pipe for oxygen that's bound to red blood cells to go anywhere it needs to, whether that's the fingers or other areas. When you have secondary Raynaud's related to scleroderma, unfortunately, you develop a fibrous interior, which narrows significantly the lumen or the opening of this blood vessel. So this is the opening now you have for oxygen to go to wherever it needs, and that's it. So when we talk about secondary caused by scleroderma, we talk about a very narrow opening, but this is not with vasocontraction. This is not with blood vessel contraction, so this is a biopsy. So now if you take this as a relaxed blood vessel and put this in, what do you think is going to happen to that vessel? There's going to be nothing there. So it's important to note that this is, in some patients with scleroderma, the best condition they can hope for. So what we try to focus on in patients who have this is trying to make sure they don't develop this on top of it with episodes leading to tissue death. So this is a typical appearance for a patient, and this is a patient with primary Raynaud's. You have this blanching whiteness to the skin, usually associated with cold exposure, but other causes as well, and typically rewarms. What we see here is we see the pallor, the whiteness. You can see a little bit of the bluish right here, and then you'll notice down here it's red. And this red is the rewarming after the blood vessels go into spasm. When they rewarm, blood influxes the area, and you get this red, warm appearance. So you're seeing the initial stage, you're seeing the bluish, the second stage, and then you're seeing actually the red third stage rewarming. This is a patient with scleroderma who has Raynaud's, And you don't see pallor here. This is the second stage. Pallor, whiteness is the first stage. The second stage is called cyanosis. You get this blue discoloration at the tips. And I think you can appreciate it more on this side, on the right side, than you can appreciate it on the left side.
And numbness.
And numbness. Yeah, and it's important to note that blood supply to anything will inhibit the function. If the blood supply is to the skin, you get whiteness. If the blood supply is to the muscle, you get weakness. If the blood supply is to the nerve, you get numbness. So all of these things can be associated. So typically Raynaud's involves episodes. Fortunately, they are reversible in most cases, and this is during the episodes. When a patient has Raynaud's, they don't have it constantly 100% of the time in most cases. They usually have episodes where it's worse and then a baseline where it goes back to wherever you started. Again, it's a white to a blue and red. It's well demarcated. See, you can see exactly where it cuts off. And if you went back to that radiographic procedure with the dye, you can kind of visualize where those blood vessels would be hit. It's due to blood vessel spasm. Again, it's a narrowing, and it's usually induced by cold. So the end result, what we try to avoid, and this is a patient who has primary Raynaud's. Fortunately, it's less common in primary Raynaud's, but I do see patients from time to time who, they went to a late season Eagles game. They were out too long. Their friends were fine. They came back, and this was the end result. So you're more susceptible to frostbite-like loss of oxygen supply. And what happens is you develop necrosis or dead skin. This eventually would dry up and fall off, and you would have a shortened finger at that point. Usually it's not surgically removed because it's not an infection that's causing gangrene. This is a dry loss of blood supply. So I have to warn you, this next slide does contain pretty graphic images. So if you are squeamish, yeah, you may want to look away for a minute. So I showed you the necrosis on the last slide, and a patient can recover pretty well from that, even with a loss of a fingertip. But sometimes, and it can be very extensive, and I do see this. So you do see patients who you can see where the blood supply has been cut off. You can see where there's dry necrosis, and this is actually bone underneath. And this is bone here and bone here. Eventually this will dry up, and again, these will come off. Surgically, with this case though, I think that they would probably try to help and get rid of some of this bone so he doesn't develop bone infection. But this is unfortunately not something, unfortunately I should say, something I do see. And probably once a year I see something not this aggressive but similar, or a patient who's had it previously. So, unfortunately also if they do surgical or when this does dry up, it's typically not taking it from here, it's taking it from healthy tissue back here. So he'd probably go beyond the knuckles and lose it up to here. There are some improvements we can make with prosthetics in patients who have significant hand disability related to loss of digital distal tips. We see here in this patient, they've lost tips at these fingers. They're going to lose this one, and you can see they've lost this one down to here, and they're going to lose a majority of the thumb. There are prosthetics that we can put in place to allow them to extend the fingers for typing. These are pretty awful ones. They actually do make ones that look like real fingers. You'd be surprised how functional they are. Highly expensive and unfortunately not paid for by insurance. One of the manufacturers in France is one of the best ones I've ever seen. And the first time when I was a fellow, I saw someone take off the prosthetics, I almost fell to the floor. It does look like a finger, absolutely. So Raynaud's, if we're talking about Raynaud's primary or secondary, there are things to do. You may have a normal blood vessel with primary Raynaud's, and you may have a propensity with a narrow blood vessel with secondary Raynaud's from scleroderma. But vasospasm, blood vessel spasm, and narrowing even further are important because they can both occur in both of those. So the most important thing I think you want to do is have dry hands and feet. And you may say, well, how does that really help? And the issue usually comes during the summer months. And I find patients tell me during the summer months that the Raynauds are worse than the winter months. And some of you may say, well, how is that possible? And that's because if you want to cool something the quickest or heat something the quickest, you wet the surface and then you apply a current of warm or cold air next to it. Because during Raynauds, from normal moisture or from perspiration, and then with cool air flowing over it, you're constantly evaporating heat and you're causing more blood vessel spasm. So this is difficult, especially with feet, because you may say, well, my feet are dry, but after an hour, perspiration basically makes anything moist, even for a small degree. During the summer months, if you have the air conditioning going, and unfortunately all air conditioning is forced air, this is where the convection currents really make things worse. Until they come up with a better way of cooling a room, summer, I think, for most Raynaud's patients will actually be worse. I do try to tell patients to make a friend with a local sheep or farmer who harvests wool, because it's important, and hunters and campers and outdoor enthusiasts will tell you cotton is the worst thing you can possibly wear for your extremities. So I tell patients to get rid of all cotton and go with a wool polyester blend. And the issue there is I would ask you, if you've ever been out in Europe or another rural area where they have sheep, have you ever seen a wet sheep? And your answer would be no. Wool does not absorb moisture. Cotton absorbs moisture. Wool actually lets moisture evaporate. So it's important to wear wool on these extremities because you can evaporate the moisture and allow your skin to be drier. And that includes wool as an underlining for gloves, which I recommend patients wear mittens because it keeps the fingers together and warmer. And that includes, a wool polyester blend. You can get them at any outdoor recreational store for the feet. And patients will wear these winter and summer and all year round. Another important part is layering of the chest wall. I'm a skier and an outdoor enthusiast, and I have friends who will say, look at my brand new Gore-Tex jacket, I'm going to be able to go and do anything. I said, I don't care about your $500 Gore-Tex jacket, I'll take 3, 4, 5 layers any day. And that is, again, we can learn the most from the animal kingdom, and that is a bird or a duck is most warm because they trap heat. Layers will trap heat. The old wives' tale was, keep your head warm and you'll be warm. And that's actually not true. Keep your heart warm and you will be warm. The whole object of your body is to keep your heart warm, because if your heart is not warm, you'll lose consciousness because it's not perfusing your brain. So wearing layers on the chest wall until the point where you feel a little bit of discomfort for warmth should help dilate blood vessels in your fingers and toes and hopefully shunt more blood that way. If you're wearing a shirt and maybe a vest, and during the winter I see these patients come in, they have a nice coat, but then they take it off and they have a t-shirt, say, I feel fine, I feel warm, but I can tell you that you're causing some contraction of those blood vessels to keep the blood at the heart, to perfuse your brain. So it's important to layer, layer, layer. And cotton or wool on the chest probably doesn't matter as much as it does on the extremities. It's just most important to trap heat. Tobacco is a big problem because the product causes blood vessel contraction. Tobacco is a huge addiction problem. I'm totally realistic on that fact. I try to, steer patients towards abstinence programs. Cutting down can benefit. Staying away from alcohol and caffeine can also benefit. Caffeine definitely causes blood vessel contraction, and alcohol actually, although causes blood vessel dilation, causes you to lose heat. So you don't want to do that either. So I tell them to try to avoid these things. So I warn you again, the next slide is very graphic, so you may want to turn away. And some may find this inappropriate for this lecture, but you have to know the reality of the situation. So we see this patient here with the coldness. She's obviously going through coronation or some royal event at the time. Anyway, oops, what happened there? There we go. It's important to realize that anxiety does cause blood vessel spasm. For primary Raynaud's, but also secondary Raynaud's, primary mostly, anxiety is going to make the blood vessels shrink. So trying to keep calm, meditation, biofeedback. And some people can become quite good at this. Of course, this is going to work better for someone who doesn't have scleroderma and a narrowed blood vessel to begin with, but I still think it's a value for patients. You go through mentalization procedures where you imagine your fingers warm and your blood vessels dilating. And there is a nerve supply to blood vessels. And again, if you become good at this kind of meditation, I think there's an appreciable difference, especially for the primary Raynaud cases. So let's talk about treatments. Some of the medication treatments that we often use are keeping a patient on a baby aspirin. And a baby aspirin will, if you think about blood vessels trying to cram their way through a cell, aspirin may make them a little more slippery and allow for more oxygenation through another cell called platelets. So meaning they're not so backed up. It's a theory that I don't think has ever completely been proven, but it's something that we often prescribe to our patients. Something called calcium channel blockers are one of our prime treatment modalities. There's something called nifedipine or Procardia. This is a blood pressure medication, and again, I think it can be useful in the right patient. It's quite often the first line treatment for patients who have secondary Raynaud's with scleroderma, but I use it an awful lot too with primary. And the Procardia, what it does is it just dilates blood vessels. There's another medication called Bosentan, and that medication is approved for pulmonary hypertension, which scleroderma patients often suffer with. And pulmonary hypertension is a blood vessel contraction of the pulmonary or lung blood vessels. Bosentan was found, though, to reduce Raynaud attacks in patients with scleroderma. So if they have pulmonary hypertension, I also use this medication to see if I can mediate some of the effects of the Raynaud's as well. There's something called phosphodiesterase inhibitors, and you'll know them more by their names, which is Cialis and Viagra. These are blood vessel dilators, and they can be also very effective for patients who have Raynaud's either from scleroderma or otherwise. My biggest issue is insurance paying for these. These are approved for pulmonary hypertension and also male erectile dysfunction. So sometimes you can squeeze by with certain creative coding. But often, unfortunately, in New Jersey, I found that it's more difficult. I worked at Pennsylvania Hospital for a number of years, and I found it easier on the Pennsylvania side to get these medications, harder on the New Jersey side with Horizon predominant coverage to get these medications. And I've actually not been successful here in the past 4 years getting these medications. There are many other treatments. It's just that these other treatments are less successful and there's less known about them. We need more study, and I plan to work closely with my colleagues at University of Pennsylvania to see what potential is in store for some of the other medications that are currently on the market. Because we borrow these medications from other causes, as I think you can see. There are surgical options where they cut the nervous system nerves to the blood vessels. I haven't seen one of those in a number of years, and it's variably successful. I couldn't say it's more than 50-50, but for a certain patient, I think that could be an option. I don't think it's an option for a scleroderma patient, but for a primary Raynaud's patient, it could be an option. So summer is coming. The icicles are melting, although it doesn't feel like it today. I'd be happy to take any questions that you have in regard to this.
Hi. Aside from the physical, the comfort level for keeping your fingers warm, does it have any assistance in like slowing down the Raynaud's or assisting with the blood flow?
In secondary causes, no. But the most important thing is to keep that blood vessel open to whatever degree it's able to. It's the episodes of the Raynaud's where they clamp down and it clamps down for several hours or longer, where you would lose blood supply and then have tissue death. So if a patient is in an icy lake and they fall in and they revive them after a certain amount of time, they do fine. But there is a point in time where the tissues are dead and you can't revive anything to that point. So Raynaud's is a chronic condition with episodes of severe, disease that can result in these end stages.
Another way I should put it is like, if my hands don't feel particularly cold at this time, is it still better to keep them warm to prevent episodes?
I would say yes, it's still better to prevent episodes, and that's why the importance of wool, layered chest wall for heat, avoiding certain substances.
Thank you.
This is training.
Is acrocyanosis common also with Raynaud's?
Yeah, I see more acrocyanosis visually than I see pallor. Patients will describe pallor, but when they come for an appointment, acrocyanosis seems to be more common.
And any other treatment besides the procardia can be done to alleviate?
There are other treatments. They use things like depression medication, and it's not that they're treating depression, it's a chemical reaction at the blood vessel. They also use other high blood pressure medications, but again, there's less commonly used, less known about them. But I do cycle through some of these medications. By the time I get to those medications, usually I'm not very successful, though. If they're going to respond, they typically respond to one of these that I outlined.
Thank you.
You mentioned one of the medications that aggravate this condition that is used for your heart, proto
Proto-inhibitor?
what?
Viagra or Cialis?
No,
Oh, Procardia.
yeah, it's a medication.
Yeah, that's a common medication. It's been around for decades.
There is slow the beat of your heart.
It can. Yeah, it can.
And it aggravate your ends.
Yeah, you have to be followed closely, of course. Patients will develop low blood pressure. They can develop slow heart rate. Most of the patients I have on this, though, that's not the issue. Yeah, you can have swelling. Yeah. Most of the patients I have don't have significant degree of cardiac disease, so fortunately there hasn't been too much of an issue as far as what they call bradycardia, slow heart rate.
What about long-term use of nifedipine?
Nifedipine?
Mm-hmm.
Yeah, and I keep them on for the rest of their life if it works.
And it's fine to use long-term?
Yes.
What would you say about bamboo socks?
I don't know much about them. They sound comfortable.
The question was, what would you say about dander socks? Bamboo socks. Never heard of it. Care to share?
It's recommended.
Sorry.
It's recommended for hot flashes, clothing made out of bamboo materials.
Apparently it's recommended for people who have hot flashes, as well as people who just need to shed heat, if you will. So
On the same note, what about copper socks and the copper gloves?
I don't think there's any data to support them, but I do think if it's possible, I guess, there's metal in the material that it might be reflective for infrared heat and may keep the extremity warmer. But again, I don't know anything to support it. And I know copper is one of those products where it does everything, include wash the kitchen sink. So, yeah, I don't think it would necessarily do anything to the circulation, but I could potentially see that it might reflect heat back to the skin.
Are blood thinners used for Raynaud's?
Not generally, no.
No.
Have you noticed people with Raynaud more resistance to heat, touching something hot? My husband calls me now asbestos hand because I can touch stuff, and he can't because he will get burned. Is it?
I can say you're probably more hypersensitive during that red rewarming phase, but otherwise, no.
Okay.
With my episodes, I've never had like extreme or bad ulceration, but I get cracks that just do not heal. I've had them since October. Very painful, they bleed. I go through all the color changes and everything, but these cracks remain. I am on certain medications, but anything, your suggestion, what might help with that?
Yeah, unfortunately, it's not. I think that there's probably, it would have to be a full examination, but it probably you're losing some perfusion of the tissues, not to a huge degree, but you're having poor healing. Yeah. You're not having enough oxygen to the area.
Yeah.
Yeah.
Okay. Thank you.
Just pass that up if you do it. Thank you.
There is no surgical procedure to replace arteries in your fingers?
Well, it's potential. They could do something like that in the future. It's a question, though, whether if you had scleroderma, would form the same problem with the transplant. And then again, you have to have transplant of capillaries. And to my knowledge, in this time in history, we're not able to do that. It's too much of a microscopic repair. But I suspect that, not during my lifetime, but at some point, they would have something available.
I was no longer taking medications. I still have minor symptoms. I mean, they still get cold, the tips get red, or white freeze. When I went out to the snow, it was like really, they were frozen. And would it be good to stay on medication? That's my question.
Well, I would think it would be good to stay on medication, number one, if it works. And that's often it doesn't.
Excuse me, I didn't hear you.
I would say it would be good to stay on medication if you think that it actually improves your symptoms.
It did improve it, yes.
Yeah, I would, if we lived in a very warm climate that didn't require air conditioning, but it was still nice enough, maybe you wouldn't need it. But I think that there's enough cold environmental changes that still you could occur. And if you took you and someone who didn't have Raynaud's, whether it was primary or secondary, put them in a cold room, you would be much more likely to develop frostbite than someone without.
Definitely. I felt that way.
Yeah.
In the cold. Didn't hold it up.
I was wondering, is calcinosis what the ulcers are from?
Well, calcinosis is usually associated with a type of scleroderma, but that's
crest.
Yeah, right. It's a limited form of scleroderma, but it's not necessarily the key is in relation to Raynaud's and ulceration. Raynaud's and ulceration again is a loss of oxygen to the tissue.
So the ulcers aren't calcinosis?
Well, you can form ulcers from loss of oxygenation, and you can form ulcers from calcium deposits as well. But they are two different things.
Oh, okay.
How about a cortisone shot?
A cortisone shot for?
Whenever any
Yeah, that's possible. That could be used, but cortisone doesn't have any benefit on opening blood vessels, unfortunately, that we know of.
You said no caffeine or alcohol, or is there, how much can you have of that?
Well, it depends on the patient, depends on the degree. I think if a patient comes in and, yeah.
Sorry, Dr. Cronin, the first session was all about alcohol.
All about alcohol, okay, yeah.
This is more about caffeine.
Yeah, yeah. Yeah. It is, right. Yeah. Yeah, there's a lot of factors involved there, so it depends on the patient.
It's part of the relaxation you mentioned.
That's right, that's right.
Thank you. Are there any clinical trials that you're excited about that they'll do something good in the
for Raynaud's?
Or scleroderma mostly.
For scleroderma, yeah, we've been involved in some things in the past, and I think that there are some things progressing. For Raynaud's, I haven't seen anything that is impressive, and I don't think that there's a lot of money committed to Raynaud's by itself. I think there's money committed to scleroderma in treatment of some of the higher causes of death, which are pulmonary hypertension and kidney disease related to it. But Raynaud's is still somewhat of an orphan. But that doesn't mean something won't work. The things that work here were not invented or researched for Raynaud's.
You know, I'm registered for the Broad Street Run, right?
Do you have any suggestions for if you have certain fingers or toes that tend to have more difficulty rewarming or damage, what you can sort of do if they're not quite like at an ulceration point?
Yeah, just those general measures there. And for a younger woman, some people say that oral contraceptive pills may actually make it worse too. So that's something to consider. But I generally don't tell my patients to stop taking them. I think if that contributes, it's a smaller degree.
Who was it? Oh, thank you.
Hi. What is the relationship between, or is there a relationship between Raynaud's and the sclerodactyly?
Well, yeah, sclerodactyly would be what you should always see in systemic sclerosis scleroderma. So the sclerodactyly is going to be then associated with the Raynaud's, and the Raynaud's making the sclerodactyly narrowing of the blood vessels worse. So sclerodactyly is I guess the best way to put it, or maybe not the best way, but the only way I could explain it would be like scar tissue under the skin, around the musculature, and then the blood vessels.
Okay, well, as a follow-up on that, then would something like procardia possibly prevent the sclerodactyly?
Unfortunately, no. At this point, we don't have a prevention for skin sclerosis. There are some trials that show maybe long-term improvement in a diffuse type of skin sclerosis, but it's still much more open as to if it's benefiting. That's the major problem. You'd be a good researcher. There you go, just dug right down to the core.